I'm Susanna, and I've been an associate here for 5 years, and I work part-time.
I'm Jan, I'm a dental therapist. I've been at the practice for about 16 years now, I think.
Wow.
Got anyone?
My name is Sapna. I'm a recent graduate and I'm about to start my foundation dentist training here.
I'm Anir. I'm a full-time associate here. I've been here for about 8 years now.
I'm Sunil. I'm the actual current DF1. I've been here since September and going to continue for another year.
It's good to have a large team to rely on. It's not just you on your own dealing with everything. There's a lot of full-time and part-time members of staff, so there's people to take slack. We have a really big patient base, and it's nice that there are different members of the team that can look after different aspects of the patient's care, and it all links in and helps in the end.
I think from a recent graduate, working into a bigger team eases that transition from university, because you are surrounded by so many clinicians, so many students, and you like working in big teams and bouncing off ideas of each other. So in that sense, I found that working in a big practice was a great transition to get different opinions on treatment plans and just develop my skills further.
How have you, Suzanne? You've been here.
Yeah, no, it's brilliant working, as I said, as you said, in a big team. But there's an extended crew as well with the student hygienists, and we've got several levels of hygiene care, and that really does help, because you can tell the patient that you need to do this, this, this and this, but if everyone's singing from the same hymn sheet, then the message really comes home. And with this patient base, there's a lot of need, and with people coming in and sort of with very little information, they leave with a great deal of impact from each one of us.
Maybe you're going to tell us a little bit about, you mentioned your practice base. What types of patients do you have that come to this practice?
I think this is considered quite a high needs area, densely in the high needs area. We see quite a lot of tooth decay and perio disease, quite a high smoking rate, I'd say, for this area.
Yeah. Yeah, quite a high level of social need. But we do have a mixture of more affluent patients as well that come along, and so there's a whole broad spectrum really of those who really care about their teeth and want to look after them, and those who've got a huge amount of other social problems and so are less able to look after their teeth.
I think you've got to have like a certain approach with every one of them, but you know, sometimes it can be a bit hit and miss. Some of the richer clientele are, you know, really happy that they've got all these facilities. They're happy to see the student hygienist, even though they could probably afford to see all the, you know, the big wigs. But they get so much from that that process.
Of being with a student, you mean, with the time and that sort of thing.
Student hygienists spend big ones for about an hour long, so they have a lot of time to go over and really personalise the treatment to the needs of the patient and discuss the patient's concerns and help them to how to facilitate how to look after their teeth.
To get to have an appointment with whoever you'd want, for example, a hygienist, a therapist, a dentist, fluoride nurse, in a reasonable short space of time. And because being such a large team, we do generally manage to accommodate that significantly well, I think.
Ability to get here and access the premises, so we've got quite a lot of downstairs surgeries. The new ones are quite large, so if people are wheelchair bound, then we can allow them access treatment.
Anything else? In terms of you have you open 5 days a week, 6 days a week?
Five.
5 days a week?
Yeah.
And do patients like that, the fact that you open, what hours do you open until?
I think preferentially they probably want us to be open 24/7 if we
Mhm.
do. You do a late day on Wednesday, isn't it?
Yeah,
So
till 6:30.
6:30 Wednesday.
and an early
8 till
morning
5
sometimes
the
as
rest
well.
of the
Yeah.
time.
Sometimes people can come in an 8 o'clock slot and then shoot off to work afterwards, which is really helpful. The same thing with GPs. You know, if you're working more, the hours God sends you, getting in to see your dentist or your doctor is sometimes quite tricky. So, in fact, people maybe who are on income support have a little bit more leeway, but the general population need to be a bit more.
Do you have waiting times that you, because you've got 10 surgeries, 10 surgeries, 6 people working, and do you have waiting times and stuff like that?
Waiting times in terms of
For getting appointments,
there is
Yeah, we do.
yeah.
Now more so than we have had in the past.
I mean popularity obviously.
That's what I was just saying, why do you get you to have long waiting times?
I think the new prototype has slowed things down
Yeah,
a little bit.
appointment times are longer now, and therefore we can see the same amount of people but less frequently because the appointments are longer, so you're not seeing as many people per day.
The students are slow, so their appointments go quite quickly, but that said, when you get your appointment, you get quality time with them. So.
We do have emergency slots, so you know generally you can still come in and see us, but to wait for a filling or an exam appointment sometimes can be a bit lengthy, but that's going to change I think with time.
You're a prototype B,
Yeah.
so that means you're a band 3.
3.
So how has that changed your sort of, you mentioned access, how has that changed access?
It hasn't.
Hasn't changed at all?
No, I mean we all follow a pretty strict sort of code that we've continued. It hasn't changed anything.
It hasn't changed the way we work, I don't think at all.
No.
So maybe you just want to explain to some students just what the band sort of 2 and what it meant working as a prototype, and then you mentioned it hasn't changed anything. Maybe share a little bit of experiences of being a band. You started in December last year, so
April.
April this
oh
year.
yeah, wow.
Well, it's very different from the UDA system that we used to have. Now, it's based on trying to see a greater number of patients. There's a great emphasis on prevention, and putting a lot of the responsibility on the actual patient, whereas before, if the patient had a problem, you would address it, and they could get the same problem again a month later. Now there's a greater emphasis. You can actually, with the traffic light system, show them whether they are progressing to regressing or staying the same. And rather than just telling you all the answers that you want to hear, that they do brush twice daily with fluoride toothpaste, you can possibly sort of question it, and they'll think twice about giving you them false answers now, and makes them think a bit more. I think makes them consider their oral health a bit more, their general health. I think it's positive, but I don't think it's changed the way we work at all. I think, not in the
We've
slightest.
always been prevention based, so
not in the
it's
slightest.
from that
It's changed the way the practice is run, and the appointments are being booked, but I don't think it's changed us clinically at all, is it?
I think our focus may be on sort of worrying about whether the patient can afford this treatment or so on, because it's kind of open-ended a little bit, because we're not running to try and sort of finish things. It's left open so they can see the students, they can see the hygienist in their according to their sort of time frame. Then that makes it a little bit easier, I think, money-wise. We're not sort of worried about meeting like so many UDAs and so on, but what we actually do is just still what we do. There's no difference. They train at university to do a certain sort of type of dentistry, and I think that's all what we've stayed with. We've not varied from that.
That's interesting you say that you felt like there hasn't been a transition, and is that just because of the way your practice is set up, do you think?
I think we were already meeting all the criteria they wanted to, in prevention, so that bit of it just hasn't changed. It's everything we've ever wanted for our patients, because at the end of the day, it is the patient that's key, so how we approach that, this has probably made it a bit easier, I think, for us to do what we do.
Yeah, and the interim care appointments have
Yeah.
been useful because you can spend time reinforcing the hygiene things that they're mostly prevention based, so you can remind patients. Whereas before under the UDA system there were fewer interim care recalls.
It was more of an
So,
optional thing.
Yeah.
Whereas now it's kind of, right, this is what you've been advised to do.
Nice to do, yeah.
And what do patients think about it?
Most of them seem quite positive about it. Some are more compliant with the advice you give them than others. The hardest part is motivating them to go home and carry out the routine that you're advising for them.
Sometimes it's quite nice with the traffic light system. So if you've got a family, if one's got better scores than the other, then it's a little bit of emphasis, bit of,
Competition.
yes, competition amongst siblings or whatever to get a slightly better result. But overall, it's been positive. There's been no hiccups or worries or.
I think some people who are used to having had a 6-month checkup for years question it a little bit. I've had that a couple of times, especially if you're recommending a 24-month checkup now. But overall, I agree.
The thing is, it's the patient's choice at the end of the day. So even if the computer has given them a sort of suggested time, it is a suggested time.
Sometimes I don't agree with it and I change it.
Yeah. So I think that's probably where obviously it hasn't
of course.
made us suddenly stop what we think is right and ethical. We'll still do what we think is right and ethical by the patient, not by our bank balance. So it's never been that way. So I think that's where it's not really changed us.
I was going to ask Shannon before
Yeah, I was just going to say
about what are your expectations about sort of, access and work before we move on to prevention. What, from your background, from your training, you're just coming into a practice, what do you think access means to you and what?
I think I agree with the definition that Anna gave, is providing the care when the person needs it, if the patient requires it, i.e. an emergency appointment is providing that care for them. Also managing the expectations, so if they're coming in expecting something, try to manage them to the best of your ability. And I think we're taught that at university, but when you're on your own, I think, you might have a few moments where you just stand back and think, oh, you need a second opinion, so it's nice to have a big team.
To me, it means sort of seeing a whole family go from, as I say, sort of from the red traffic sort of sign to a green, and making the future appointments sort of really boring and all about their holidays, because they've done everything they should have done, and they're basically caries free and happy.
I think care is free, especially for the children. We do have a large percentage of carers-free children within the practice. There's also a proportion that show a lot of decay, and it is trying to encourage them to change their ways and prevent something that shouldn't be happening, especially to children, but to adults as well and the elderly.
I think it's the same, just all hygiene areas, just investigating where the cause is and making sure you address that before you move on.
It's almost like doing a risk assessment. Each individual patient, you have to assess their individual risk of getting any oral disease and address it accordingly. Doing that risk assessment and predicting how things may go if you don't intervene and educate at that point. That's what it is. That's to prevent, rather than waiting for something to happen and then treating it and then prevent it from happening again. But if you can prevent it from happening in the first place, that's probably what the intention would be. With children, like Jan said, it's probably more educating parents is a lot of what we have to do rather than the actual child, which is the bigger challenge I've found than actually talking to the child. parents that you have to sort of change their way of thinking and their habits, and then everything follows suit.
Yeah, I think it's like trying to stay away from that drill and fill mentality, because at the end of the day you need to address what exactly has caused this in the first place and go back a few steps rather than just see the disease, fill up and say, okay, come back in 6 months and then we'll do another checkup. And like I said, it's all about education, and especially in the high needs area, you get many people who are surprised with the things you say that you take for granted that everyone should know.
Like what?
Brush twice a day, use TP brushes, and probably the biggest thing is people using mouthwash straight after brushing their teeth, and they're all surprised, oh, but it says on the bottle, and you have to give them the reasons why, because I think people tend to understand things more if they know exactly why they're doing it rather than being told do this rather as an order. So it's all, I think it's all about education. But prevention can be on many levels. You can speak to the patient, you can do demonstrations, and there's different ways to deliver it. So I think it's about exploring and seeing which patient takes on information which way, and then adapting yourself like that.
We don't, but we do. We do talk to them
We
about
do
it.
the signposting.
Okay,
Um,
tell us about that. How does that look like?
In as much as we discuss their smoking habits and are they interested in giving up, and the reasons why they should be giving up, and then where they can seek further help. I think we do have one girl who was trained to give smoking cessation, but we don't generally have appointments set up with her, but the patients will quite often go off and think about what you've said and come back and say they did seek the advice that you gave them as extra advice to help give up.
So it's quite rare for someone to take it on board, because when you do give that advice, the general response is, I've heard it before, yes, I know. But you also have to tell them you have that duty to give them the information, and then give them all the different pathways they can take, because it's not just through the dentist, they have the GP, they have other different ways. But even if it's that constant message, if they've heard it that one time might make a difference. I don't think it's something they should just skip because other people might be doing it, or their GP might be taking care of it. So we have that position where, as dentists, we see them regularly enough to give them that message constantly, and do that assessment and see how they're getting on. You might say, oh, they've gone from 20 to 15. It's still progress. You encourage them, but at least you know they're not getting from 20 to 40. So
Surprisingly, some patients have more time to see us than they do to their own GP, or at least we know them better than
yeah,
their GP. So it does count.
yeah,
It does count, and I think, there have been a few good instances where people have come in and said, especially on the hygiene front, I've given up smoking because, so it's not going to happen necessarily at the first appointment, but the regular input from all of us encourages them to give up.
And then if they want to bleach their teeth and things like that, then we say, well, it's not much point unless you do this, and then think about all the money you save to do that. So it's like sometimes a little
motivation.
Yeah.
Yeah. It's having patient satisfaction. If a patient is satisfied, you know that you've provided quality work, but as an individual you always have your own standards, which might not be the same as others, but you always want to do the best to your ability. And when you have that patient at the end of the appointment being so appreciative and come back and saying, oh, that feeling was great, I've had no problems, I think quality would be determined on how well a patient takes your treatment.
I think for me it was more, I think it would be just offering and providing care that you would, to the same quality and same standard that you would expect, or someone, a close member of your family, the way you would treat them. Treat everyone the exact same way, to the same standard that you would want to be treated, give them the same advice you would want to be given, give them the same options you would want to be given. That's, if you can stick by that, then you can't really go too wrong, I don't think.
Yeah, agreed with both of them actually. Also just like expectations and managing the expectations, knowing where you stand. So if you know it's out of your remit, then just maybe referring it on and getting a second opinion, just to give them the best quality care.
I mean, it's tailoring it to the patient's needs, you know, looking and seeing exactly what that patient needs and what they can achieve, so that they can go away and make improvements for themselves. Otherwise, you can give lots of treatment, but if they're not looking after it and helping you, then it's not a quality thing. So, and having the time to do that is important.
Yeah, so you use about time as well and
Yeah.
tailoring.
Obviously, I agree with everyone.
You can disagree.
No. I think it's the long game. It's, you know, that's where, sort of like you said, that everyone's an individual. You don't want to have the same approach for everyone. So you might only have like a small win with, say, someone who has a disability and they're only able to achieve so much. But it's actually a big win, the fact that, you know, they're happy and they're stable and they keep coming. And, you know, obviously not yet, but the point where, you know, I'll have children who've grown up and now have children and their care is free. I think that's quality. I think that you've been able to reach through. But it's also spending time. You know, no one should be shortchanged. I think, you know, I think we're all good clinicians, but I think the day that you didn't have the time, if you really brushed off your feet, or you know, and you weren't able to give 100%, that wouldn't be quality. But I think we do. So all is well.
So as a practice, what do you think you do to maintain quality in your practice?
Well, we do have regular meetings as well, so we kind of, you know, touch base with each other. But also, I don't think any one of us is too proud to go to the other person and go, well, this is the case, I had a case like this, what would you have done? And, you know, 9 times out of 10, we would agree with each other. But there's no harm in asking, well, you know, what was your perspective on that? And, you know, we're quite lucky, again, to have younger dentists who have, you know, sometimes different techniques or different ideas. And they also learn from the older dentists that I've actually been there, done that, got the t-shirt, and you should probably, well, no, maybe you should try this. The problems are when, you know, you maybe you're in a single practice or you don't welcome change. I mean, all of us are a bit stubborn, I'm sure, but, you know, we welcome change. We find out from each other sort of what the best approach might be, and hopefully we'll find that out.
Yeah.
I think quality also stems from when the patient walks in, meeting reception staff, the nurses. It's not just the dentist who provides that quality, it's the whole practice experience. Even when they leave, have to make the payment, that communication that they have, booking the next appointment, how easy it is. I think that is something that we all have the same mindset of. When you do work in such a big team, it's easy to pick up on how this practice runs or what everyone's ethos is, which makes it easier to fit in and develop that and standardise that across the whole practice, so patients don't see a huge difference from going from one dentist to other. So that for them it's quite easy just to be moved around to say from go from the dentist to the student hygienist, because everyone has that same ethos.
Time constraints if you're having a really busy day, or if you're running late because you've had unplanned treatments and things. That's always difficult.
I think it's getting that patient through the door in the first place, because if they don't have that education early on, then you do get those FTAs quite regularly, and they will never essentially get the message. And when they do come, it's always an emergency when they're in pain and they're not focused on their overall health. So it is a little bit frustrating thinking that there's a lot to be done, but they only think there and then, they're not for the long term. So that's probably, for me, as a frustration when you sit there and you see a patient and then they don't turn up, and you know they need some care. So I'd say the barriers on 2 levels, as well as a patient, but as well as from outside.
Is that, I think, also a attention to self. So like a mum probably remember to bring her kids in on a regular basis, but maybe doesn't find time for herself to get something done, or if someone's a carer and they're looking after someone else, again, their needs get shoved under the carpet. Or like, you know, sometimes also as a clinician, like you put your heart and soul into trying to rehabilitate them, but life goes on and you might not see them for another 2 or 3 years, and then by then obviously things have gone back to where they were, and you know, I think it's about being patient, but those are sometimes the difficult bits.
Sometimes it's difficult to appreciate some patients' chaotic lifestyles and what's important to them outside of the dentist. And dentistry is very low on their list of priorities, and then that's a huge barrier to them coming regularly and having the care they need. And cost can also be a barrier, even though it's NHS supported for some families. Cost is prohibitive.
And what do you do to try and overcome some of those barriers?
Try and be as positive as you can and explain their needs and work with them. But
I think what Jan C said is right. Just understanding that they may have other priorities outside. And when you show that you do understand that you're not just going on about the same thing every time, and you do understand that and work with them in ways to try and fit your advice into their routine, I think they appreciate it. I think that works quite well. It's understanding and realising that they do have other things that may, for them, be taking precedent over what you're trying to say.
I think what I found was the biggest challenge is understanding the cost side of it, because at university you provide the gold standard without even thinking about the cost. And then you start to have that conversation with patients, start to reject that best treatment, and it's hard to comprehend that you have to not go against that. But I think that's a step that you need to take from university to practice and be comfortable with talking about cost and accept that patients, like Anya said, have other things outside of their oral health that they're more concerned about.
Sandra, what do you think would be the main challenges for you following on what you were just saying about that transition?
I think I agree with the cost, because we've never ever at university said to a patient, this is how much it would have cost. You know, we've provided implants at university and we've restored implants, and at no point we've thought, oh, this would have cost so much in general practice. So we don't think about that aspect of things, even if it's material. So I think that just generally the cost to patients, as well as just running the practice itself, you don't think about it. And I think that's something that's about to shock us all, because, you know, we might not have everything that we need, which is gold standard, but, you know, you've just got to work with it, and you've got to use your general common sense, I suppose.
treat every patient as an individual and try and base the treatment on their needs.
Keep a very open mind, because you'll think you know it all when you leave university, but within that first month you'll realise how much you don't know, and make use of everyone around you, because everyone's got an opinion and it'll build in the way you think about things. So definitely keep an open mind when you start.
Yeah, especially what you said earlier about BT. I mean, like if you've done well at your BT year, it's down to your nurse. So it's generally, you know, if you've got an awesome nurse, then listen to her. Like, especially if she said, like, you know, Mrs. So and so has a weird nervous tick, don't look at her face. You know, little things that.
Yeah. It's even about because it's not just the patient. You have to learn about whole new computer software, and it all makes part of the appointment. And that's why the nurse is so helpful, and you've got to keep them on your side.
Anything else?
Just reiterating what you said, just don't be afraid to ask for help. Don't feel like there isn't anyone there to help you, that you're on your own. If you're in a small practice or a busy practice like this, speak to your friends, speak to your colleagues, speak to your trainers, nurses. Everyone's going to have advice for you.
There's no stupid questions. And there's like your time to make mistakes, really, so you're kind of buffered by this lovely warm environment, so make use of it.